How do we work relationally in our treatments and then extend that out to the entire family and the systems that serve kids? Well, first we need to build a workforce. We need to have a workforce that understands the critical issues facing this special population. So having a basic understanding of addiction, trauma, child development, those are key. Knowledge of attachment, the things I just talked about, and the stress that comes with disrupted attachment. Having developmentally tailored services for young children, being able to know what is appropriate and how to intervene for a 1-year-old in the way that you might do with a 4-year-old. And then a critical piece that was mentioned earlier was building provider reflective capacities. So addiction, like not very many other issues, and trauma in little itty-bitty babies brings a lot of feelings from providers. Very good doctors, very good providers that I trust, that are amazing physicians and amazing clinicians, I hear saying things that are very stigmatizing about families and wouldn't make me as a parent want to come back for services. And because this issue stirs up a lot of feelings in us, and so this needs to be built into our workforce and training opportunities that we're given. What are some of the barriers and opportunities we have? So all this stuff sounds great, right? But how are we going to pay for it? Well, in our state at least, billing reform is a huge area that we're working with. We've been working with 0 to 3 on the policy convening to identify some ways in our state that we can be able to bill effectively for our services. Right now, we are very limited. I'll talk a little bit about our HEALTHYSTEPS program in a minute. We're unable in our primary care integration program to bill for mental health services without a pre-authorization that takes some time to review. If there's a woman in front of us that we know has a risk for a mental health issue, or her child does, we're not able to intervene and bill for our service. And even when we do, the reimbursement rate is pretty low. We don't have differential rates for evidence-based practices. We're trained in a whole host of EBPs in my clinic, but it doesn't matter if we deliver that service versus another, and other states have tried to do that differently. There's codes that are closed that aren't currently open to us for case management. We know families who are in crisis take a lot of case management, and often that is the hook for engagement to get families to come in. Mom might not come see me to get help for mental health, but if I can find her a crib or get her help with housing, that's going to give me the buy-in so that she'll come back next time. But if I can't bill for that service or that time, then that's lost time. Enhanced investment in social emotional services through Part C, so our early intervention programs. We really struggle to have service coordinators who are appropriately funded to manage the high service needs of that population. So they're really operating kind of on a bare bones structure, and we could really use a lot more investment in that population. Many babies who have substance exposure in utero automatically qualify for our Part C services, whether or not they have developmental delay. So that's a great opportunity to be able to interface and provide that coordination, but those coordinators are spread so thin, it's really difficult. And also consultation in the hospital. Only MDs at this point can bill for consultation liaison services. So if I want to provide some more psychosocial support to a mom in the NICU, I'm not really able to bill for that either. So lots of opportunities here where we have the skills and we're mobilizing a workforce, but there has to be something to meet us on the other end to make it sustainable. Thinking about effective intervention. So typical parenting skills programs, while great, are not often tailored to the substance use disorder population. And as I've mentioned, there's lots of specific needs that those families have that we need to be taking into account. So it's not going to be a one-size-fits-all parent management program for these families. Psychoeducational approaches, where we're just giving information to families, we know these don't really work. They're really not that effective because they're just scratching the surface. They're not really getting down into the deeper issues. But all of the issues that I've already talked about developmental tailoring, trauma responsiveness, family-centeredness, these are the types of competencies that interventions need to be infusing in order to be effective. So one model that we're trying and using in our family medicine clinic is the HEALTHYSTEPS model. So this model recently came to 0 to 3. This is a behavioral health integration model for pediatric primary care, but we're using it in family medicine. A smaller subset of practices are doing this, which is wonderful because that means we can intervene in both generations, both at mom, during pregnancy, and then follow that child along for their pediatric primary care. So the way it works is we have a HEALTHYSTEPS specialist who is integrated and embedded into that practice. So she's physically there. She does primary care visits hand in hand with the physician. And any parent that comes, up at risk or has a concern can see her separately. We try to enroll her in our clinic because, as I mentioned, she cannot bill for mental health services unless they are enrolled in our mental health clinic. So we're still trying to work through those issues. There are randomized control trial evidence for adherence to well child visits, on-time immunizations, developmental screening and referrals, and patient and provider satisfaction. Lots of positive outcomes with the Healthy Steps model. So the next wave of Healthy Steps is really to think about sustainability and how can we help this live on our own. Right now we're grant funded, we're foundation funded. So we're really looking to how we can keep this going long term. The FAN model, this is another model that we use out of the Erickson Institute. It's a national model for family engagement and reflective practice. So this is a model that can be used in a range of settings. Medical practices, we use it in early Head Start and mental health consultation. I use it in supervision all the time. I mean, there's lots of different ways you can use it. It was initially developed for challenging infant behaviors, such as frequent crying, difficulty sleeping and feeding. These are things that babies with NAS often experience, so it's a perfect match for this population in particular. And really what it does, rather than taking a top-down approach, gauges where the mom or the parent is ready and validates her experiences without trying to fix it. We see a fussy baby or a baby that's having difficulty, it's very easy, even as a provider, to try to jump in and say, well, have you tried? Have you done? You know, and often mom's response is, I've tried everything, you're not hearing me, this is really difficult, there is something wrong, and I cannot figure out what it is. The ER doctors are telling me she's fine, but still she cries all night long, and really just being with that mother and being able to support her emotionally through that experience, which takes a great deal of self-regulation, and that's where the reflective practice piece comes in. So the website's here if you're interested in learning more about the model. We are within agency trainers in the state of Maryland for this model. And then dyadic treatment. So one of the evidence-based practices we are trained in is child-parent psychotherapy. I am trained in this model and use it in my practice. Child-parent psychotherapy is a dyadic model that really explores the meanings of children's behavior. So not just looking at how to change non-compliant behavior, but what is the child trying to tell us with that behavior? And how does that interact with the mom or the dad's own history of being parented? What things come up for you when your child is aggressive towards you, or calls you a name, or won't listen? You know, what kinds of things does that stir up in you? So bringing together the intergenerational cycle of trauma, substance use, loss, forefront into the treatment. Again, multiple RCTs have demonstrated good outcomes for this, both in terms of child symptoms as well as maternal symptoms. So even though it's not an adult-focused treatment model, it's still effective for maternal depression and post-traumatic stress.